Everybody, welcome to this web series. So, as people are joining in, I think it's time to move on. I welcome the moderators for the session, Dr. Anup Gupta and Dr. Kumar Narayanan. And I'm just going to put everybody on mute. The moderators can kindly unmute themselves. Uh, Dheeraj, can you put everybody on mute, please? Okay. Over to you, Dr. Anup Gupta and Dr. Kumar Narayan, please, to start the session.
Thank you. Thank you, Vanita. And I welcome Kumar also as a co-moderator. Two presentation today and both from Gujarat. First by Niraj and second by Shomu. So Niraj, again, is a very young dynamic electrophysiologist doing pretty good in Ahmedabad. He's going to speak on heart failure and atrial fibrillation. Over to you, Niraj. Niraj, you are not audible.
Neeraj, your mic is off. You can stop sharing and share again. Maybe that will work.
Niraj, I think you have to go to your headphones or use the microphone of the computer, either of the two.
Hello. Hello.
Your voice is very faint, Neeraj.
Am I audible now?
Yep.
Very low. Can you increase the volume on your mic?
Now is it okay?
No, your volume is very low.
Just a minute. Is it audible now?
No, the
Hello.
volume is very low. Okay, can we do this,
Hello.
Anup, that we can start with Shomu's presentation and Neeraj can log out and log in again?
Yeah.
Yes. Yeah. We can do the same thing. So let Shomu speak on the right-sided pathway. So again, Shomu is the Superman of Gujarat in electrophysiology. Very bright guy. And I'm pretty sure, everybody will enjoy because his presentations are always very good. Very impressive presentation. Shomu is yours.
Thank you, sir, for the kind words. I'm really thankful to Vanita Madam for giving me an opportunity, though I have been tending to avoid because of being late in most of the days. So it's my pleasure to present on right-sided accessory pathways. And thank you, Madam, for giving me this topic because I had to read a lot for this. So thank you so much. So starting the accessory pathways of the right side are lesser common than the left side. If you say right postroceptal or postroceptal space will be 1/4, but the lateral free wall pathways would be around 13 to 21% and anteroceptal space would be around 2%. So in 91, in NEJM, Jackman et al. Had published this data saying that the characteristics of the pathway and right-sided pathways in that the only retrograde pathways were less common. More common were both retrograde antegrade conduction or antegrade conduction, and it included atriovascular pathways. So we are not counting on that in this discussion. So what are the right-sided ablation rules? The first rule is use ECG as a potential guide for mapping, that we do in all. Second, always have a dedicated right side catheter, especially when you are using less catheters. When you are using just 3 catheters, you tend to avoid a right side catheter. So right atrial catheter dedicated should be used. Third is you use a decapolar catheter along the tricuspid annulus if possible. Fourth would be use a sheath for stability and maneuverability. And fifth would be use the typical rules of pathway ablation, including pathway potential and earliest A to V, and then use of 3D mapping and ICE in difficult cases. And we'll discuss each of the things now. So ECG as a guide, if there is pre-excitation, is very helpful because, as we said, retrograde only would be less common in the right side. Most of them are either bidirectional or antigrade only. So in this, it's a simple rule: V1 negative, tricuspid annulus, and then see for V3. V3, if it is positive, it becomes a septal towards septal or a parahesian or a right posteroseptal pathway. If V3 is negative, then it becomes a right anterior towards the lateral part, right lateral pathway, or a right posterior pathway. And depending on the number of inferior leads which are positive, if more are positive, so all three are positive, it is a right anterior pathway. If all are negative, it's a right posterior pathway. And if one or two are positive, then either it is a mid-septal or a right lateral pathway. So this becomes easy to see further. For practical guide, you may choose right anterior, right posterior, right anteroseptal, right mid-septal, right posteroseptal, right anterolateral, right lateral. But as I said, this would be a very easy way. And what is the importance of this use is, if you have a right anterior based on ECG or a right lateral based on ECG, you use a sheath for stability of ablation. If you have a parahesian pathway or a mid-septal pathway, you may require cryo-energy or you require RF titration. You cannot go with the full titrated dose of RF energy. And if it is a right posterior septal pathway, then irrigated tip catheter and mapping the CS may be required. So practically this algorithm helps. Now, what is the importance of a right side catheter in the right atrium? So normally it's a tendency to put all three catheters, the ablation catheter and the decapolar in the CS. But then if you have a right-sided pathway, use the ablation catheter to go into the right side, right atrium, and you might require to pace it. So pre-excitation may come only if pacing from the right side many a times in a right free wall or a right posterolateral pathway. And if you don't have a right-sided catheter and you have a AVRT, which is inducible without pre-excitation, a long VA during tachycardia with central conduction on a CS catheter, then you should map on the right side. So this is a classical example when we used this. In the left side, you have pacing from the CS, coronary sinus decapolar catheter, and you can see that there is very partial pre-excitation. The moment you pace from the right side, on the right hand side, there is full pre-excitation. So it's very important to pace from near the pathway in such a situation. Also, as I said, in a AVRT, if you have a concentric conduction in a CS catheter, decapolar CS catheter with the earliest A in the His, you need to go to the right side to map so as to see whether there is any pathway on the right side. So how a decapolar catheter on the tricuspid annulus helps, and this is what I do generally in all of my cases. If I have a suspicion of a right side pathway or a atriofascicular pathway, I don't need a decapolar in the CS. What I will do is see the ablation, try to see where the pathway is, and then put this decapolar out and keep it along the tricuspid annulus. It gives me 10 poles along the tricuspid annulus, which is very helpful. And this is how it helps. So according to this, so this is a tachycardia continuing, and you have a decapolar catheter along the annulus, and you have the CS12 marked. So this is the decapolar distal marked as the earliest. And then you put the ablation catheter like this. So here of the 10 poles, you have the earliest here. So I need to map the same area. It becomes very easy. It's like the guidance of a CS catheter for a left-sided pathway becomes the guidance of a decapolar catheter in a right-sided pathway. The fourth way I use for a right-sided pathway would be to use a sheath for stability. And for a right anterior pathway, I take the sheath near the mid part, while for a right lateral pathway, it goes up and lets the catheter come down in a position where it can be actually parallel to the annulus, which gives good stability. And we'll see the applications of it in individual cases. The fifth And the most important is use the same principles of mapping and ablations in the right side as you would do in for all pathways. So right bundle branch block during tachycardia with increased cycle length would prompt you to map on the right side. Use unipolar signals for mapping a pathway. Ablate at the site where you have a pathway potential, but most of us possibly may not see it. So you have to ablate within 20 milliseconds of the earliest far field or the earliest A or V. So localization step would be ECG, pathway potential, and earliest AV when the pathway potential is not seen. So this is a classical example of a patient having AVRT, and you see here the cycle length with the narrow complex would 270 millisecond, and suddenly there is RBBB. The cycle length increases to 294. That means the pathway is towards the right side, and obviously you have to go. And this is central conduction, so obviously I'll be going to the right side to map. So during wave pacing, occasionally you may see a pathway potential, and it's very important to have a pathway potential in the unipolar rather than a bipolar RF distal. So unipolar will say that it's at the tip, and that's where you need to ablate. While the earliest AV that we generally use if the unipolar is not good is also a surrogate marker. And most of the times I tend to map during tachycardia rather than VPACE because central conduction may cause a change in the activation characteristic, especially in a mid-septal or anteroseptal pathway. So definitely during tachycardia, it is very important to map. During a AVRT, it's important to map for the earliest retrograde A rather than in VPACE. In patients who do not have a retrograde VA conduction, mapping is done actually during pre-excitation, but it's important to pace nearby the site. So it's very important to pace nearby the site rather because a right-sided pathway, you will have antegrade conduction via the AV node also. So if you have a paraseptal pathway, then you pace near the his posteriorly. If you have a posteroseptal pathway, you can pace the CS-OS, and if you have a right lateral pathway based on pre-excitation, you can pace the right free wall. So when you pace in this patient, it was being paced in the CS910 for a posteroseptal pathway, and you get good pre-excitation, and then you see for unipolar and bipolar signals to get the site of ablation. The last and the most difficult part would be using 3D mapping in difficult cases. So there have been cases where 3D mapping has helped, especially in failed ablations due to the insertion away from the annulus due to epicardial pathways, maybe appropriate for anteroseptal pathways, but most common failed ablations are unable to keep the catheter stable. It is useful for difficult anatomies like Epstein's and for ablation without fluoroscopy. So fluoroless ablations, 3D mapping, and ICL is helpful. So let us go for examples one by one. So we'll have three special, parts: right lateral, posterolateral area, right anterior, anteroseptal and midseptal, and right posteroseptal, right posterior regions. And then there will be special situations where RA A tip to RV, WPWAF, especially right posterior, WPWLV dysfunction without any arrhythmias, and patients who have ablation away from the annulus where the atrial insertion site is more than a centimeter away from the annulus. Lastly will be epicardial ablation for occasional patients. We'll not be discussing about Epstein's, PJRT or atriofascicular here. So the first group example is a right lateral, right posterolateral area, and you have a typical transition away from V3. So V4 is positive, but V3 is negative, and 2, 3 here you can see 3 and AVF is negative. So it is basically a right lateral, right posterolateral area. So once you know this, you need to have that sheath for stability. So difficulties in a right lateral or a right posterolateral mapping would be that it is difficult to recognize the annulus many a times. So the signals on the atrial site of the annulus may be misleading because of the fold that the atrium has over the annulus, and then you can have far field ventricular signals inside the atrium itself. And the second part would be difficulty in stability of catheter in the lateral tricuspid annulus. So to answer that, I have already told you that you need to take the sheath up, have the decapolar here and pace it from here. So you can now see that this catheter decapolar gives you a way to know where the annulus is, and you have the ablation catheter at the annulus itself. So this helps by various, so pacing near the part will give you more pre-excitation, because in a right-sided pathway, you don't need a decapolar catheter in the CS, so better use it on the right side. It guides the area to map, it delineates the annulus as a reference, and ablation during right atrial pacing from the decapolar catheter from the nearest site of pathway, which shows good pre-excitation. So you need to pace the pole where you suspect the pathway to be by either retrograde VA conduction or by pathway ECG. So this gives you stability. So if you are atrial pacing, sudden VA block, if it is there, the catheter will not move. Or if you have a tachycardia ongoing and you do the ablation during tachycardia, suddenly the catheter movement will not occur. So this is generally possible only during pre-excitation, which is generally present in a right-sided pathway. So regarding answer to the stability, proper use of the sheath. So I could have used the sheath as in figure 1, where the sheath is down and directly the catheter goes up along the annulus. But what happens here is you have an end on to the annulus. So this catheter, ablation catheter, goes end on to the annulus. So the chances of displacement is high. Also, the area of impact is lesser as compared to the second figure, where my sheath is up and I come down in a way such that the ablation catheter is actually parallel to the annulus, and the whole 4 millimeter tip actually goes along the annulus, so that I have a good stability. The advantage of using this way is you get very good stability signals, as well as even when the tachycardia terminates during an ablation, as you can see here, the tachycardia terminated during ablation. The second beat is a pre-excited beat with a partial pre-excitation, and the third beat, as you can see, is non-pre-excited. So still the AV ratio doesn't change much. So you have a very good stability of the catheter with this position. The second group would be a right anterior anteroseptal pathway, and I would take a little bit more time on this. Again, similarly, you have V1 which is negative and V3 which is positive, and 2,3 AVF which is positive, so it becomes right anterior or a paraseptal pathway. The anatomical equivalent would be that it is very near to the non-coronary sinus of the aorta. So anterior region is not near, it's the anteroseptal where the His bundle is there, and the mid-septal is not near. So you need to consider ablation only if it is near the His bundle, right? So the difficulties are, especially in an anteroseptal, is mapping in the anterior annulus. Second is bumping the pathway, which is not uncommon. Third is localizing the pathway when it is very near to the His, because the signals get merged with the His signals. And fourth is ablation site to decide to avoid AV block. So let us answer the first question. Again, the sheath importance is here. Use sheath and use multiple catheters. You may actually remove again the decapolar catheter and place back into the RA appendage near the anterior. So you have actually 3 right-sided catheters and 1 catheter in the aorta itself, which can actually map the whole area together. And if required, you can go to the left side and map the left mid-septal part also. So once you have these many catheters, it is easier to map. The second part is anteroseptal pathways. Many a times we have found that they get bumped. So be gentle while mapping this area. And this also means that the pathway is endocardial. It's near the site only. The problem is once it gets bumped, it may not come back for 30-40 minutes and you'll have to wait, or it may not come for the duration of the procedure and it becomes difficult. The third is pathway localization. So as I said, multiple catheters, and second is map the aorta in the non-coronary sinus. It's very important. Importantly is to differentiate retrograde pathway and nodal conduction, and that is most easily done by the earliest site of atrial activation during a narrow complex tachycardia. If you use V pacing or a paraesian or a RV apex based pacing, it just tells you that there is a pathway, but it doesn't localize. So localization, most importantly, would be during tachycardia, narrow complex tachycardia. And bump mapping sometimes can help you to localize. If you have a 3D, you just mark that area where it bumps and then you can go back to reference. So mapping the aorta in the non-coronary sinus, and as you can see that it's very easy to go out there. Now the fourth important point is where to ablate. So ablation site to decide. Ablation, if it is away from the His area, anteriorly especially, then you can do it safely. Prefer a V more than A in the signals and prefer to ablate in tachycardia, and we'll discuss why. Ablation, if it is done at the site of His, where the potentials are seen at the site, the earliest site, then you have to always ablate during tachycardia. And why during tachycardia? Because if you are ablating in sinus rhythm with pre-excitation and the pre-excitation doesn't go away, you might have actually ablated the AV nodal axis and still there is pre-excitation, and the more you ablate, you might actually cause a AV block. So it's very important to ablate during tachycardia. Even in V pace, if you ablate, the problem is there may be a VA block, but you will never know that antegrade conduction has gone or not. So it's important to ablate during tachycardia. Second is prefer ablation in non-coronary sinus if the near field signal in the aortic sinus, so non-coronary sinus, is within 20 milliseconds of the far field earlier signal. So if you have a far field earlier signal, say in the His, and in the non-coronary sinus it is late, but it is within 20 milliseconds, you can still prefer ablation in the non-coronary sinus. However, if you don't have a signal which is within 20 milliseconds, then you have to use the unipolar tip electrogram to find the potential or the earliest V. There should be hardly any atrial potential where you ablate. With a large V, this will prevent chances of AV block. Also, additional methods to decrease the risk is use of apnea with GA. So the patient can be asked to hold the breath, but that's very difficult to hold the breath for 20-30 seconds. So people do anesthetized and give apnea during the GA. Use of jugular access like this, go from above so that it's stable and hook on the superior region, or you can curve the catheter from the RV to go back into the recess so that you can have a more stable position. So let us see these examples. Here you have a transition in V3 and 2-3 AVF positive, but initial R in V1, V2. And then earliest A was in the His. So this is atrial pacing inducing the tachycardia, and you have a His signal. The earliest A comes within the His area, and the ablation catheter shows the same. And then you map the area, you find that this is the earliest, and you have a small His signal here again. So then you go back to the non-coronary sinus, and from where you get a sinus signal, the A should be more than the V because the non-coronary cusp has A more than the V. And then induce the tachycardia, and you see whether these signals of the A are earliest is within 20 milliseconds of the His, and if it is so, you ablate. So ablation during tachycardia terminates the tachycardia with a V, suggests that the retrograde limb has blocked, as well as there is no pre-excitation thereafter. So both times, so you always have a best result during and post ablation, the patient had a VA dissociation. The second example, similar ECG. The pathway, however, gets bumped in the anteroseptal region, and you know that now you are dealing with a very superficial pathway, and thereafter the tachycardia is not inducible, but pre-excitation comes intermittently, and you see where it bumped, you have a map distal showing AHV, and now you're without pre-excitation. It is very clear that you have a good H in the area. Now try to induce the tachycardia, but there is just a single beat coming. It doesn't sustain. So what do we do? How do we ablate then? Waited for half an hour, nothing happens. So here you are mapped retrogradely well during the only beat, which shows that the map distal A is the earliest. However, the A to V ratio is very large here. So then you go back and see whether you can see in the aorta or not. So go in the aorta and try to ablate in the opposite side. So started ablation in the aorta during sinus rhythm. Now the problem is you don't have a tachycardia. So the best thing is you have to do it in sinus rhythm with pre-excitation on, and then the loss of pre-excitation happens. However, it occurs after 6 seconds. The wattage is around 35 at that point of time, and we have given an ablation for 30 seconds. However, it comes back again. Even after increasing the wattage, it doesn't go back. So then we go back in the RA, but just then a little bit anterior. Here the site of ablation was A less than V with a small His signal seen, and the third beat you can see at the start of ablation is a junctional rhythm, and then the ablation is continued, and then the patient doesn't have anything further. So the patient has loss of pre-excitation with loss of no tachycardia with VA dissociation. The third example in this situation would be intermittent pre-excitation. You have clearly early His signal in pre-excitation and mapped in the site in aorta, but no success at all. So now what do we do? So this is a tachycardia continuing. You have a very good signal in the mapped distal with a good H seen, and then we start. So this is the start of ablation. Immediately within 2 seconds, you have a right bundle branch block, and within 4 seconds, the tachycardia terminates with a V. So no A, and the patient remains in RBVB, but no PR prolongation, no AV block. So here in this example, you can see that the ablation catheter is positioned just anteriorly to the His with the V, which is more, the A is hardly there. And this is the area which can be safe, but it is superior. The extreme example would be this patient who had incessant tachycardia. The patient remained in tachycardia throughout with pre-excitation. He was having literally tachycardiomyopathy, and an ablation attempted in right bundle was not successful. An ablation during tachycardia caused an AV block here. And you can see here the signals during AV block, the H. So it actually was an HV block, and had given the ablation at a very small A, the H was lesser than the His distal signal. So this was just inferior to the His. So this is the His, this ablation inferior to the His. So the patient required a pacemaker. So fluoro position for risk of AV block, if you consider, the highest would be just below the His. That's the place where you don't want to ablate. Even if you have a lesser H, you go more ventricular, you may end up with the AV block. Going superiorly to the His towards the right bundle, going much more superior to the His from the non-coronary sinus, or anterior away from the His towards the lateral aspect is a safe position. Precautions are junctional rhythm can be there. Now you can see that if during ablation tachycardia terminates, I would think that this is good. No, but if you see the VA shortening, and this is actually a junctional acceleration that is happening, causing the termination of tachycardia. The second is, be very careful if you start ablating during sinus rhythm, because you can see this fully pre-excited beat. The moment this happens, you have to stop ablation. There may be actually junctional acceleration later on. So important points is, unless incessant, do not ablate in the parahesian region. During the first study, if infrequent tachycardia is there, let the patient demand. Risk of pacemaker is less, but it is real. You can start with a lower energy, 30 watts, and titrate upwards. Cryoablation, if available, can be preferred, and recurrence is higher. However, in cryoablation will be reversible AV block during testing. A word about the other apicardial aspect would be the RAA to RV connection. And we have had two patients which I could not bring out. These connections are actually located 1 centimeter apical into the RA appendage. So you get an A earlier in the RA appendage than the annulus, into 1 to 3 centimeter ahead. So you have a large A in that. The V is very small. And you have to do the ablation inside the atrial appendage, and generally it is within 10 milliseconds of the earliest far field activation. Accessory pathway potential is not recorded, and sometimes you need to do multiple ablations. There have been reports using 4 to 17 ablations for actually removing this kind of pathway. The last group would be a posteroseptal posterior pathway, and generally this doesn't cause much of a trouble, but you need to be careful that mapping in the CS is required, especially if you have a small r in V1, the delta is totally negative in lead 2. And if you have a small r in lead 2, then you have to map the CSOS where the slow pathway generally region is. You may require cool tip catheters for successful ablation, and you need to wait a little longer and give adenosine always post ablation to check the success. The problem is, if you have junctional rhythm in near the CSOS, a narrow QRS during ablation can give you a false sense of success, and then suddenly it can cause AV block. There have been case reports of the same. Again, hence you should ablate at a site where A is less than V. Similarly, here this is a patient within the CSOS we ablated, and very good signals, and you can see the A is lesser, just a bit lesser than the V for ablation. right posterior pathway generally doesn't cause much of a trouble, and it can be easily done in either during the tachycardia or sinus rhythm. The problem is right posterior pathways are especially prone for atrial fibrillation, and when this happens, you're stuck. But most of them will have associated AVRT and you can ablate during sinus rhythm or otherwise. But there are some patients who go into recurrent incessant atrial fibrillation, and what do you do next? You cardiovert, and but they go back into atrial fibrillation. So this is a patient who has an incessant AF, WPW. Then you just use a unipolar recording with a bipolar signal showing good A and a unipolar showing good V, and map to the earliest. The moment you do an ablation, it's narrow complex and the patient's pre-excitation is gone, rate is controlled. So these are occasional patients which might come. Remaining special subgroups would be these three. This is a patient with LV dysfunction, just pre-excitation, no palpitations at all, very wide complex. Holter suggested narrow complex beats, thus confirming pre-excitation actually. And then we went ahead and just did an ablation. There was no inducible tachycardia during the study. Post-ablation, full recovery of function was there. So certain patients who have pre-excitation and LV dysfunction, you need to ablate such patients. There have been case reports, and I think Dr. Yash also had a case similarly, where the ablation of a right-sided accessory pathway where the atrial insertion site was far away from the tricuspid annulus. And this was done by 3D mapping. And if you see that around these 10 patients were used, and if you see the distance between the atrial insertion sites and the annulus was around 20 millimeters. It's 2 centimeter away from the annulus. So you need to see, and the use of a decapolar catheter, if you're doing a 2D mapping, would help actually if you find signals which are early in the decapolar catheter as compared to the annulus, and therefore find such patients. Also, epicardial ablation of a pathway. Again, Dr. Yash had this presentation in the last IHRS meeting also, where certain pathways which do not go and require an epicardial ablation, and these are rare though, and right free wall, right posterior pathways can be there. So last would be words about right-sided pathways, but not discussed. PJRT, origin nearly from the CSOS right posterior region. Mahim, I'll not discuss much, otherwise we can go on for hours. And Epstein's, where you can have up to 25 to 50% of accessory pathways, but right-sided pathways are much more common and multiple pathways are much more common. In addition to the issues are distorted anatomy, antidromic tachycardia, long VA conduction times, and the problem of a intra-right atrial conduction and prolonged infranodal conduction. So concluding, right-sided pathways present a challenge for ablation. Appropriate knowledge of anatomy and options is important. Success depends on mapping, and avoiding complications are important. Thank you.
Wonderful, Somu. Extensive talk. Few questions which has come on the chat box. One from the Yash. He has asked, like, you said, like, you put decapolar along with the tricuspid annulus in each and every case of right-sided pathway.
Yes.
So he says that it's sometimes very difficult to place it along with the annulus and maintain it there. And does it really help? Because we have never done this. And the
Yeah.
same thing, like, the comment what Dr. Makkar has given, like, he said, like, rather than putting a deca, he will try to put a deca with 20 poles, so 10 remains inside the CS, rest outside. That can give a better stability.
Yeah, Dan, I completely agree with the second part, duodeca. So more the poles, the better it is. The problem is when you are doing a simple case in a private, you are taking 3 catheters, right? Now, to add on a catheter, to use a special catheter, it again requires permissions and again connections. So this is the easiest way out. Regarding Dr. Yash's question, I used to find it's okay, but then after putting it properly every time and making it stable, the way we put it helps, especially in pacing. When we pace from the right side, you have a stable position. And the second part is to see the retrograde. So atriofascicular, you don't have retrograde. But in a pathway, a retrograde conduction, earliest A helps, especially where exactly it comes. And then you can just map around that area, it helps.
Okay. The second thing, what you made, like, for the right side pathway, you always prefer to use sheath. So Ashish Nabar is asking, when you're using a sheath, how do you select your curve of the catheter, whether you want to keep a D curve or a F curve or E curve? How do you
So
select that?
in a normal patient, I used always a D curve. If you have an Epstein's, it's always a large curve. So depending on the anatomy, if suppose the patient is a normal patient, then we use a D curve only. A small, so if it's a child, especially my patient child, then we may use a small curve. But otherwise, it's a regular standard curve, D curve blue catheter.
When do you, Dr. Makkar has asked, when do you consider performing upfront CS venography to look for diverticulum
Yeah,
with the
so
given target ECG?
So I think there have been papers from Dr. From Bangalore and also from Pondicherry. If we have lead 2 which is totally negative, so lead 2 which is totally negative, and personally we feel that a very sharp downstroke in that lead 2. Along with that, if you have a deep S wave in V5, V6 and a very small R or a very flattish R in V1, all these prompt us to actually do a venogram preemptively. Now, when you have a tachycardia, so during a tachycardia, if you have a earliest activation which is wedged between the CS os and just the middle cardiac vein area, both are early, while the CS posterior region is late, or the right posterior region is late, then also we go ahead with the CS angiogram. And we do it not by a coronary shoot, we actually use the SR0 sheath. We hook in the onto the ablation catheter inside that, push the SR0 sheath inside and do a hand injection in the SR0.
Great. Dr. Yadve is asking, like, how to predict antroseptal pathway will go from aorta or from ablation from the antroseptal area.
Yeah, there have been some people who have said that an initial R in V1 suggests a little bit of a left side involvement and might go from aorta, but in clinical practice we have had many patients now and I have given the examples. Most of these patients have a small V1. So as I showed the fluoroscopy, if you have a anteroseptal pathway with the earliest activation at the His catheter, not below, not right side, not laterally. If it is bang on the His area, then it generally goes from the non-coronary sinus. But if it is just below or if it is just right side, it doesn't go.
Kumar, if you have any comments or any question?
No, I think very comprehensively he has covered. So some questions which I had planned to ask were already covered in the talk. So I think we can move on.
I hope there are other comments also. I would also. Dr. Yash is there, so he would definitely, he has done some cases away from the annulus and epicardial also.
Yes, you want to make any comments?
No, two comments. Of course, Shomu has done a wonderful job in a short time, and I think there are many tips here for the younger and this EPs. There are many important points that he's made, and I hope they have been listening. 2 points is, one is the coronary sinus angio. I mean, we should have a low threshold to do it. I would say any we should actually, the term posteroseptal is a big misnomer, and we'll be part of a paper that is not near the septum. But whatever, what we call posteroseptal, any posteroseptal pathway, I would straight away, any doubt in the beginning, do an coronary sinus angio. And if you're using a SR0 sheath like Shomu does every time, it's fine. Otherwise, we just put a AL1, and a AL1 catheter directly hooks the coronary sinus very easily, or with a Terumo wire. So I think it's straight away one should do it beforehand. And the second point that I would like to make is that, the ablating from the non-coronary sinus is something people are very worried to do and are a little reluctant to, but there's no logical reason why you should not do it more often, because you'll be surprised in the superoparaceptal or the anteroseptal pathways, almost a significant number of them can be safely ablated from the non-coronary sinus. So otherwise, I think Shomu has covered most of the points. Yeah. Incidentally, the pathway that we had published it was inserting into the SPC RA junction.
Yeah.
So it
Yeah.
had positive P waves in 2, 3 and AVF during tachycardia.
Right.
I think with the interest of time, now we'll move to the second talk. I think Neeraj, now your audio should be okay. So thank you, Shomu, again for
Thank
the
you, sir.
wonderful presentation.
Sir,
And it's to Neeraj.
am I audible now, sir?
Yes.
Okay. Hello.
Yes, go ahead.
Yeah. So the second talk is more of a clinical talk, not an electrophysiological talk. Uh, I'm going to talk about AF and heart failure, and this presentation would be on overview on management of AF in heart failure patients. So this is a complex situation. For example, if we look at the cases that I managed recently, all of them were different, and so was the management of each case. A lady of 64-year-old presented with AF and rapid ventricular rate, new onset LV dysfunction, failed rhythm control with antiarrhythmic drugs, received pulmonary vein isolation. A patient who is 56-year-old male, status post mitral valve replacement, comes with LV dysfunction, failed rate and rhythm control, receives AV junction ablation and conduction system pacing. Patient of severe obesity, obstructive sleep apnea, AF and rapid ventricular rate with preserved ejection fraction, failed rhythm control, receives rate control and referral to bariatric surgeon and sleep physician. And patient was told to pursue rhythm control after reduction of significant weight and addressing his sleep apnea. So it is very important for clinician to figure out what contributes more in producing patient's problem to be able to formulate a management strategy in this group of patients. When we ask physician through Google Forms about what do they think is the most common reason for hospitalization of patients with AF, majority of them answered symptoms related to AF and heart failure. Minority replied stroke and unrelated cause as the reason for admission. And this is why symptomatic improvement and heart failure management should be the primary goal of managing AF patients. Prevalence of AF and heart failure is increasing with increased longevity of our patients, but unfortunately they live longer with lot of comorbidities which make them vulnerable to problems like AF and heart failure. Majority of risk factors for AF and heart failure are overlapping, and probably that is the reason why we see both conditions coexisting with each other. If we look at the prevalence of AF in heart failure studies, it varies from 5% to 50%. And prevalence of AF increases as the functional class of heart failure deteriorates. Whether AF is a cause or consequence is an area of research. What we know is that AF by rapid and irregular ventricular rate reduces the ventricular filling, and loss of atrial systole and functional regurgitation reduces the cardiac output further. Majority of these cases have also a component of tachycardiomyopathy leading to LV dysfunction and heart failure. And AF itself produces some cellular and electrophysiological changes to promote AF. Heart failure by increasing filling pressure, increasing LS size by producing LS stretch, and some neurohormonal activation and dysregulation of intracellular calcium promotes atrial fibrillation. So heart failure and atrial fibrillation are closely interrelated, and interrelation is relatively complex. In Framingham Heart Study, out of means 1470 patients developed AF, heart failure, or both, out of which 26% developed both, 40% had AF first, 40% had heart failure first, and 20% developed AF and heart failure on the same day. Incidence of first heart failure in AF patients or first AF in heart failure patient increases the mortality by twofold. And this cumulative incidence progressively increases with duration of follow-up. This was a small but interesting study by Pozzoli et al., who followed up 344 patients with heart failure and sinus rhythm, out of which 28 developed AF, which became chronic in 18 patients. With development of AF, NYHA class worsened, VO2 max declined, cardiac index reduced, and functional regurgitation increased. 9 of 18 patients died after AF, and he concluded that occurrence of AF was a predictor of major adverse cardiovascular event. But prognostic significance of AF in heart failure is not that straightforward. There are some studies which showed that AF was an independent predictor of MACE in heart failure patients, while other studies did not show AF as an independent predictor of mortality and labeled it just as a marker of advanced disease. Because there are other factors which determine the impact of AF in heart failure. Like in very advanced heart failure, AF will not change the natural history. But in patients with heart failure who is in compensated phase, new onset of AF can rapidly decline the clinical status. And these are the patients where AF should be managed very aggressively. Four main therapeutic consideration remains anticoagulation, rate control, rhythm control, and management of risk factor as well as other comorbidities. Anticoagulation, NOACs have significantly reduced stroke, systemic embolism, major bleeding, and intracranial hemorrhages in a heart failure patient. And there is no interaction in efficacy and safety of NOACs between AF patients with and without heart failure. Coming to rate versus rhythm control, AFFIRM was the largest trial of pharmacological rate versus rhythm control, and it showed that rhythm control provides no benefit and actually had a trend towards harm in general population with atrial fibrillation. But we need to understand that only 9% of individuals had NYHA functional class 2 or greater. That means majority of these patients were either asymptomatic or minimally symptomatic. And 76% of these patients had a normal ejection fraction. Moreover, in these rate and rhythm control pharmacological studies, only 24 to 63% maintained sinus rhythm. Subgroup analysis of patients with heart failure suggested favorable outcomes with maintenance of sinus rhythm. Also, it was seen that benefit of sinus rhythm was actually offset by hazard of antiarrhythmic drugs. AFCHF study, this was the first randomized control trial of pharmacological rate versus rhythm control in heart failure population. And almost 1,300 patients were randomized to receive rhythm control strategy, mainly by amiodarone versus rate control strategy. And these patients had a mean ejection fraction of around less than 30%. And it did not show, amiodarone did not show any benefit over rate control strategy in reduction of death, stroke, or worsening heart failure. And again, there were some limitation. There was significant crossover in AFCHF study. Again, like in AFFIRM trial, benefit of sinus rhythm could be offset by hazard of antiarrhythmic drug. We don't know how many of these atrial fibrillation were new onset AFib in a pre-existing heart failure, or those were the chronic AFib associated with heart failure. There were other trials of rate versus rhythm control strategy in heart failure, which pointed benefit of rhythm control strategy like Diamond and CAFE2 studies. This is a case example of 65-year-old female with history of hypertension, diabetes. She presented with symptoms of heart failure, and her symptoms progressed from NYHA class 2 to class 4 in 3 months. Despite 3 different rate controlling medicine, her heart rate was not controlled and she came with severe heart failure. This was her LV function at the time of presentation and her ECG showing AF with rapid ventricular rate. Patient underwent cardioversion and amiodarone was prescribed for rhythm control strategy. Patient remarkably improved, heart failure remarkably improved with improvement in ejection fraction. However, the sinus rhythm ECG had a extremely prolonged QT interval and there were episodes of non-sustained VT also. So this case was actually the perfect example where rhythm control strategy improved heart failure status, improved ejection fraction, but still there was a danger or harm in form of proarrhythmia produced by the rhythm control strategy adopted by antiarrhythmic drug. So finally, this patient underwent RF ablation with maintenance of normal sinus rhythm at 6 months of follow-up. She is just on beta blockers and oral anticoagulants. So again, for rate control also in heart failure subset, we don't have many drugs except beta blockers and lenoxin. And there has been a controversial role of lenoxin in heart failure patient, some of them showing harm, evidence of harm by using lenoxin and some showing the benefit. In MEDIT CRT patients, actually digoxin was associated with increased risk of ventricular arrhythmia. Also, the beta blockers, which is a drug of choice for patients with heart failure, reduced ejection fraction, and normal sinus rhythm, it has not shown any improvement in terms of survival benefit or benefit of cardiovascular hospital admission in patients who had heart failure and atrial fibrillation. So we have a very limited actual disease modifying rate controlling medicine when heart failure happens with atrial fibrillation. Pulmonary vein isolation, either by RF ablation or cryoablation, is the mainstay for AF ablation as a rhythm control strategy. And multiple observational studies have shown its superiority over drugs in maintaining sinus rhythm. Though randomized control studies of RF ablation in AF and heart failure are few and small, they provide important insight into management of these patients. All of these randomized control studies showed benefit of RF ablation in reducing AF burden, improving quality of life, reducing heart failure hospitalization, and even mortality. ATTACK AF trial compared rhythm control strategy by RF ablation versus rhythm control strategy with amiodarone. And these patients actually had device in place, so the arrhythmia burden was monitored. And what it showed that rhythm control strategy by RF ablation was superior by reducing by improving AF-free survival in 70% of patients compared to 34% in amiodarone arm, which led to improvement in hospitalization rate and quality of life. Camera MRI study, again, it was a randomized controlled trial in 68 patients of non-ischemic LV dysfunction and AF to ablation versus rate control. All these patients underwent MRI for EF and late gadolinium enhancement assessment. Patient who underwent RF ablation had a significant improvement of ejection fraction 18% versus 4% in rate control arm. Moreover, this benefit was significantly more in patients who had no late gadolinium enhancement in cardiac MRI. This study actually also suggests that even in patient with suspected tachycardiomyopathy, rhythm control strategy by RF ablation was better than rate control. So even in AF tachycardiomyopathy, there is some component of LV dysfunction which is directly mediated by AF, either by irregular RR interval or by some neurohormonal uh, activation. Castle AF study was again a very important randomized control study which assessed mortality and heart failure hospitalization outcomes. Uh, all of these patients had devices like ICD, CRT for assessment of AF burden, and RF ablation significantly reduced AF recurrence, and it resulted into reduction in death or hospitalization for worsening of heart failure. Benefit on heart failure hospitalization was apparent very soon after the RF ablation, but if you see the mortality curves, mortality benefit was only apparent after 3 years of follow-up. This underlies the importance of long-term maintenance of sinus rhythm and need for long-term follow-up of these patients for significant mortality benefit by ablation therapy. Meta-analysis of RCTs of RF ablation versus drug therapy again, which includes latest Cabana trial also, showed benefit of RF ablation over drug therapy by reducing mortality, hospitalization, and recurrence of atrial arrhythmia. Mortality reduction was mainly driven by improvement in heart failure patients. Non-heart failure patient had no mortality benefit by maintaining sinus rhythm with RF ablation. And male as well as young individuals less than 65 years of age did better with RF ablation compared to drugs. But we should also understand that benefits of RF ablation in randomized control trials are in selected group of heart failure patients. We cannot offer RF ablation to all patients with AF and heart failure. Younger patients with less comorbidities, less advanced LV and LA dilatation, non-ischemic LV dysfunction with negative late gadolinium enhancement in MRI, and recent onset AF and heart failure are good candidates for ablation. While elderly patients with multiple comorbidities, advanced heart failure, more severe LV dysfunction, severe LA enlargement, and fibrosis in the ventricular myocardium are not very good candidates for RF ablation. Of course, operator and center's experience is also important for better outcome in this group of patients. There are patients where rate control strategy is the only choice and drugs don't help. AV junction ablation and pacing is the most reliable way of achieving rate control. However, there is a risk that patient will become pacemaker dependent for their entire life. In studies have shown initially right ventricular pacing with AV junction ablation was done very commonly, but then studies have shown the benefit of giving biventricular pacing to these patients who undergo AV junction ablation. Biventricular pacing by preserving LV volumes had a better improvement in LV ejection fraction in these patients undergoing AV junction ablation. Now, with experience of conduction system pacing, like his bundle and left bundle pacing can also be a good alternative to BIV pacing in this subgroup of patients. This was a 52-year male, status post mitral valve replacement, LA of 6.5 centimeters, severe LV dysfunction, and failed rate control strategy. He underwent left bundle pacing and AV junction ablation. Last but not least, another important aspect of managing AF is management of risk factors and comorbidities. Uh, Dose effect of sustained weight reduction in maintenance of sinus rhythm is similar to amiodarone. Obstructive sleep apnea is an important modifiable risk factor for AF, and other risk factors including hypertension, diabetes, alcohol, physical inactivity, they are absolutely critical to address while managing these patients. And in summary, AF and heart failure often coexist. AF, when happens in heart failure patient, it adversely affects the outcome of heart failure. Management of AF should be an integral part of management of heart failure. AF can be managed well if managed earlier in the course. RF ablation is superior way of managing AF where it is feasible. And management of AF has to be combined with risk factor management and other guideline directed medical therapy for heart failure. Thank you very much.
Excellent presentation, Niraj. I think it was not easy to summarize AF and heart failure in 20 minutes, which you have done very well. I think AF and heart failure is the classic case sometimes of the chicken and the egg. We don't know which came earlier and what is causing what. So I think therefore it's especially challenging to manage. You covered most of the points very well. So I think a question which was there in my mind, and also Dr. Ashish Nawar and Dr. Yadve have asked, is there any data on heart failure with preserved ejection fraction as far as AF is concerned? How does it behave differently?
Yeah, so there are data that atrial fibrillation also adversely impacts the heart failure with preserved ejection fraction patients. They usually lead to more hospitalization and ablation as a rhythm control strategy. But these are all observational studies. There are no randomized studies like we have in reduced ejection fraction. But I have not gone into detail of those studies, but yes, there is observational studies in heart failure with preserved ejection fraction also.
Yeah, I think the preserved EF is still more of a black box, and at least there is some reasonable data now on systolic dysfunction. The other question which comes up is how do you approach the issue of CRT in a patient with AF and who's otherwise a candidate for CRT with severe LV dysfunction and white QRS?
So, patient with, again, we have to take into account that how long the history of AF has been in this patient. If patient has got a prolonged history of LV dysfunction, left bundle branch block, and recent ECGs are showing AF, probably will go ahead with CRT, cardioversion, maintenance of sinus rhythm with antiarrhythmic drugs, and then take a call according to the response of antiarrhythmic drugs. But if patient has remained in atrial fibrillation for a long time and he is a non-case of chronic persistent AFib and there is LV dysfunction, heart failure, and LBBB, then probably CRT with AV node ablation is a reasonable strategy, especially when atrias are adversely remodeled and dilated. Uh, so it depends on what kind of AF patient is having, whether it is a paroxysmal or chronic persistent AFib. But if it is paroxysmal or new onset persistent or short-term persistent, then we'll try to achieve rhythm control strategy and CRT. And if it is a long-term chronic persistent AFib, then probably CRT plus AV node ablation. When patient has got left bundle branch block, it is difficult to tell that how much component of that LV dysfunction is because of the tachycardiomyopathy. So it is actually a clinical assessment. But if you have a wide left bundle branch block, uh, to believe that entire LV dysfunction is completely tachycardiomyopathy related is difficult to tell.
Yeah, that's a good point. I think the other issue which comes up is, before you go ahead with AV junction ablation, you have given, I think, a good attempt at cardioversion, including, a DC cardioversion. And the other point, which was sometimes mentioned, but I think it's an unusual scenario that sometimes when you have not been successful, because when you're trying to do a pace and ablate strategy, some people, they are going to put the device first and wait a few weeks before you go ahead and do the ablation. And then it may be worthwhile one more attempt at cardioversion in case there has been some favorable effect of CRT in the course of those few weeks. There's one more question from Dr. Ashish Nabha regarding the practice of mace surgery in rheumatic valvular heart disease around India. What is your take on that? And we can ask some of the others as well. How common is it in your experience?
Mace surgery.
For when they are operating on rheumatic valvular heart disease, are they commonly do the mace?
So I think I have not much experience because our surgeons don't do it. And I think Dr. Yash and Dr. Anup, they will be the better person to answer this question because I have seen hardly few cases, one or two cases maybe, which were done mace surgery. And in majority of those patients, we had ultimately atrial standstill and we had to, implant a dual chamber pacemaker.
Dr. Anup, any
Good question,
comment?
Ashish. Yeah, good question, Ashish. Like, some of the surgeons definitely, when, the LA size is more than 5.5 centimeter, they are performing maze. And I've not seen like, people performing only LA maze. They are doing bilateral maze. So in my center, my surgeon, he definitely perform maze. I know a couple of centers in Ahmedabad who are performing maze regularly, but they go for bilateral maze. It's not only LA maze, they go for the RA maze also. And what Niraj was saying, like, now not very quite often we see like, people requiring pacemaker after maze. They do pretty okay, but how long they maintain cynicism, that's the question. The reason is, unfortunately, in our setup, in our practice, these patients, they keep on following with the surgeon. They don't come back to cardiologist or electrophysiologist to see what is happening. So long-term result of maze in at least in our centers and in our part of the India, I'm not sure about it.
Yeah, I think in the traditional cut and sew maze also is a little complex, and many of the, I think, current day surgeons are not very familiar with that. But when they have the cryo probe, they should at least try and do that, is what I feel, if they are anyway operating.
So sometimes we have, in fact, requested our surgeons, but then again, it was not done. So
actually from from KEM days, and Ajay Nayak actually had done that study with our cardiac surgeon Anil Patwardhan, who was doing the maze with the bipolar cautery. Hello, am I audible?
yes, sir.
Yes, sir.
Yeah, and we used to in those days even realize that how difficult it is to get transmural lesions, despite having one bipolar cautery. So not easy to get transmural lesions. So I don't know about with RF catheter when we do ablation how well we get the transmural lesions. But having said that, any patient undergoing a valve surgery, valve surgery and having AF of significant AF should undergo a combined maze procedure. And most of our surgeons, I mean, we have several surgeons in Bombay who do a RF maze either with a simple cautery or with the the Boston or the other companies. They have that sort of specialized equipment, and it's not difficult. From what our surgeons tell us, it's not difficult. As Anup said, results are variable. We don't have full follow-up, but there is hardly any morbidity, no mortality, and hardly any added morbidity of that simultaneous maze. So my logic is that why not do it? If it works, it works. If it doesn't work, okay, it doesn't do harm.
True. I think we are done with the session if no more questions or any more comments?
I think it's a good opportunity.
So this is Paul. I'm actually listening. Am I audible?
Yes.
Yeah.
Yes, Paul.
So I just want to share my experience in the US. There's actually, since we do quite a bit comparatively more here because of the fact that it's covered by insurance and become routine care. What I've heard from the surgical side now, surgeons approach it in different ways. They obviously like to do the appendage ligation when they do it, and very big proponents of taking patients off anticoagulation, even though it is still not in the guidelines. Obviously they do heroic acts, which we don't probably advocate or have the courage to do. Secondly, you're right. The true cut and sew maze is difficult and time consuming, which is a big deterrent factor for a lot of the surgeons. But with the advent of the bipolar cautery or even the cryo maze, a lot of them are now, they don't have any hesitation to do it in terms of when they're doing another valve surgery. And actually, for me personally, and was mentioned earlier, burnt out, persistent AFibs. I personally feel it is a good shot for the surgeon to have a try at it first, because anytime, esophagus is not a friend for us, unfortunately. Although there are tools like Deviate and other stuff to move, it is still a major concern for those of us who do this on a regular basis. So when we have asked, and there's some protocols that we are developing actually to have either the surgeon go at it first so that they can truly achieve a posterior box lesion. And I try to tell them not to do too much, because anytime the more lines you draw, you're setting up for a flutter for more work for me later. Now, if it works, it's great, but many times the lines can be an issue. So I try to reserve their actions to just creating a PVI plus a box, and probably they're much better at getting a mitral isthmus block than we are in getting through the endocardial side, because they have access to the valve and can give deeper lesions. So those are kind of a limited approach to them, or a limited maze is something that I found that actually works well for the patients, especially if it's long-standing persistent AF, and people who with devices, you want to give them some benefit in light of the data from Castle AF trials. So yeah, if you can encourage them, instead of pushing cut and sew maze, just to do the cryo or the RF, may work actually with a hybrid kind of approach to use. And when I say hybrid, I'm not talking about the epicardial ablation. I'm saying a coexisting management of surgeon along with an electrophysiologist to do the limited lesion probably can work, is my experience.
Thank you, Dr. Chakyo, for your comments. I think it's all over to Vanita. Thank you very much, Shomu and Niraj, for a wonderful presentation for this evening. And I'm handing over to Vanita for the final comments.
No. You have done the final comments. Final comments, in fact, now should be coming from Dr. Yash. Sir?
No, I think, Vanita, if we can, have the next the next 2 or 3 which you already may have planned in advance, then it might be better, because now January's plan or the next 3 or 4 weeks plan, you already have it ready, or you are going to make it as it comes?
So we have it planned for till first week of January. I was just thinking, sir, thinking aloud, in fact, should we reduce it to, sir, for 1 day a month instead of doing it every week with people returning to work?
Yeah, I think probably once a month or once in 2 weeks at the most.
Once in 15 days is a great idea.
I don't know. To decide about which week to do it, it is better either we go to once a week, once a month. That should be a good idea. So we can always increase it in case we think we have the need.
I think that's fine. But if someone misses that day,